myself Dr. Priyanka, and I am one of the StudyMRCPI mentors. So we are doing this second video on of a OMR series in the early pregnancy module, which is on ectopic pregnancy. So this OMR series videos will definitely boost your MRCPI OSCE exam preparation. So do like and subscribe our StudyMedic YouTube channel, and also press the bell button icon so that you will be regularly updated with the recently added videos. Thank you.
Priya, you can move to the next slide and probably we can start the task with the timer on.
Yeah, so do not forget that don't wait for the opportunity. You have to create the opportunity. So, yeah. Hello, I am Priyanka. I am one of the exam candidates. I have read the scenario and I'm ready for the discussion.
Okay, so you have gone to the scenario. So what additional information you would want to gather from her?
Yeah. So my patient has come with complaints of in early pregnancy with complaints of vaginal spotting and also pain in lower abdomen. So here I want to know about first I want to know how much she is in pain, and if she has like if the pain is unbearable, first I would like to offer her some pain relief and then settle her. Then I want to ask her about her complaints about what is the severity and the duration of pain and the location of pain, whether it is on the right side or the left side, and what are the provoking and the relieving factors for the pain. So also about the vaginal spotting, I want to know if it is just a spotting or if it is like heavy bleeding or passage of clots. Then coming to the obstetric history, I want to know whether this is a first pregnancy or like if she has, especially if she has any previous history of ectopic pregnancy, because as she is having a positive pregnancy test with the vaginal spotting and pain in lower abdomen, I want to rule out ectopic pregnancy. Then after the obstetric history, I want to ask about the any history of cervical smear history. Are they up to date? Because that can also cause spotting per vagina. Then I want to ask her about medical history. If she has any previous gastrointestinal problems and also any previous renal problems, like renal tract problems, like any ureteric calculi, which can also cause acute abdominal pain. So that history I want to ask. Then surgical history, any previous history of surgeries in the past, and also blood group, her blood group, and any reservations for blood transfusion is important if in case she requires any surgical management. So knowing the blood group is important, and her allergy histories I will ask. Then after signposting her, I will ask her about the smoking and alcohol and drug history, because smoking is also associated with an increased risk of ectopic pregnancy. And about her social history, I will ask her about her social history. And then afterwards, I will arrange the investigations. I will also inform my consultant and the midwife, and I with the radiologist. I would like to arrange a scan for her, a transvaginal scan preferably, to know the location of the pregnancy, as she is having a positive pregnancy test, and also a blood test for the beta HCG and the complete blood count.
Okay. So this Mrs. Sarah Jeans, so she's 31 years, as you know, and she's having this pain abdomen since 2 days, and it has become worse. And it is associated with a bit of giddiness and a syncope as well once. And she has a significant history of recurrent PIDs in the past, which has been treated completely. Obviously, there is a history of multiple sexual partners for her as well. She's a smoker who smokes around 20 cigarettes per day. And she is a primary gravida. This is her first pregnancy, and the bleeding, whatever she had, was very minimal. Apart from that, she doesn't have any allergies, and she has not undergone any surgeries before. And coming to the investigations, her full blood count is normal as of now. Her beta HCG is 1,600, and the scan shows the intrauterine live pregnancy in the on the right fallopian tube and with the fetal cardiac activity being present. And there is a very, very minimal fluid in the pouch of Douglas. Now, you have got the history and the investigations. How would you proceed about managing this patient?
Yes. So, with her history and like having she already had a risk factors for the ectopic pregnancy, having like smoking and also with multiple sexual partners, and according to the investigations, it looks like that she is a candidate for a surgical management because her beta HCG is above 1500. That is, and also the transvaginal ultrasound is showing that there is a cardiac activity, so uh, uh, which is not suitable for an expectant and medical management. So surgical management is the best, will be the best management in her case. Surgical.
Okay. So, yeah, okay. What would you do if she is requesting for medical management, methotrexate, because she says that one of her friend had before? How would you counsel her for the same?
Yes, so I want to know about her recovery of her friend first. How did she recover from the ectopic pregnancy and how is she doing now? Then, because I want to sensitively tell her that each case is different and in the management is different according to each case. So maybe she had management for which medical management was most suitable. Like she had low beta HCG or a scan criteria which she can have a medical management, but in her case I will sensitively explain her that there can be risk associated of if we continue the medical management, there can be risk of having a tubal rupture, in her case increased risk, because as she's having symptoms also in a or like of having a imminent rupture, because she's having a syncope and giddiness, and also with the 1600 beta HCG and also with the live ectopic pregnancy. So I will explain her the risks and will try to explain that surgical management will be the most suited for her.
But is it indicated or contraindicated?
Surgical management is indicated in this patient. Medical
No,
management
no, no. Methotrexate. Methotrexate, is it indicated or contraindicated?
methotrexate is contraindicated if there is a live ectopic
Yeah.
pregnancy.
Yeah, so that's the first thing which you would be talking to her, right? So it's okay to know about her friend's status and all, but you have to tell her that we cannot give. It is one thing is because of the live cardiac activity. Okay. So how do you decide for the surgical management and how do you go about about the surgical management?
Yes, so here the surgical management I will explain her and the relatives what it involves first, and the risks and benefits of having the surgical management, and that is the ectopic pregnancy will be tackled at once. The follow-up will be less as compared to the medical management, but at as it is a surgery, so there can be an increased risk of like anesthesia and surgical problems. And also I will inform my consultant and also the anesthesiologist and also the specialist midwife and for the and arrange for her surgery. So after the after and we'll send the labs, that is the complete blood count to know her hemoglobin levels, and uh, mostly for her, as depending the surgical management will depend upon the type of surgical, whether it is a salpingectomy or salpingotomy will depend upon the status of the tube in which the pregnancy is, the ectopic pregnancy, and the contralateral tube. So if the contralateral tube is healthy, so salpingectomy is usually preferred. If as in her case there can be a risk, as she had PID, so depending upon the contralateral tube status, it the management will be.
Okay, so definitely for example, you think that you have done a salpingotomy because she had a history of recurrent PID. How do you proceed for the follow-up?
Yes. So as she had salpingotomy, so the follow-up is more as compared to salpingectomy. So here there will I will, while discharging her, that time I will do a beta HCG, and also I will explain the red flag signs to her, that if she has any complaints of severe pain abdomen or any again bleeding or any giddiness, so she has to contact, and will give the emergency contact numbers of the hospital. And then we'll follow her up with the weekly beta HCG values, and until it becomes the non-pregnant levels, the follow-up will be till then. Weekly follow-up of the beta HCG levels, and I also explain the red flag signs.
Okay. Like any contraception advice for her?
Contraception will be usually won't be like I think
No,
so.
in view of her multiple PIDs, in view of multiple PIDs, what else you would want to tell her?
Yeah, so here in I would like to advise her contraception, but as she had multiple PIDs, so I won't usually suggest an intrauterine device for her. So she can choose to have oral contraceptive pills, uh, but
And
not
also safe sex practices, right?
sex practices. Yes.
Yeah. Okay. Okay. I think, yeah. What's your reflection, Priyanka? So I would be giving my feedback as well. What's your reflection? We have just done with the 10 minutes.
Yes. So, in this ectopic pregnancy case, taking history is most important to come to the diagnosis correctly and to ruling out other causes of other differential diagnosis, like in case the obstetric causes, like to ruling out any molar pregnancy or a threatened miscarriage and ectopic pregnancy. So, knowing the beta HCG values is more important, and the transvaginal findings, which will rule out the molar pregnancy and the this also the ovarian torsion, the ultrasound will help in the diagnosis, even the tuboovarian abscess and the non-obstetric causes. So any history of previous ureteric calculi or in acute appendicitis, the specific uh, uh, right iliac fossa pain will rule out the and the ultrasound will rule out the diagnosis. So in pelvic, as in her case, she had a history of pelvic inflammatory disease. So knowing those uh, symptoms is important. So here, as I said, that history in what is the character of pain, knowing the pain character duration is important in her case, and um, other to ruling out other
Yeah.
causes like any gastrointestinal symptoms, to rule out any GI causes is important, and and also signs like pallor tachycardia to know the severity of the complaints is important in her case. So uh, yeah, so usually the management will depend upon the beta HCG values and transvaginal ultrasound findings, and also plus with the clinical features. So as in her case, with all these three features, the surgical management was best for her. And in this case, is no, telling the red flag signs is very important. If they are for the follow-up, or like if they choose to have medical and expectant management, if they fall in that criteria.
Okay. So the thing what I felt was, so your history taking was really good. The examination, probably after the history taking, if you could give a bit of time for me, okay, to tell you the history. It's always a good idea, right? Because after the history, because you covered till the examination, the investigation. So if you could give a bit of, you just leave a gap of 30 seconds. If the examiner wants to add, that's okay. So then once that is done, when you are talking about the management, it's a good idea to tell expectant and medical is there. However, for her, it is not suitable. Okay. And the surgical management options you told very correctly, there was no problem. And contraception, particularly, I was looking for the safe sex practices because of the multiple PIDs. And because if you do not give, obviously, she can talk about, if you don't talk about the barrier things again, she might get a infection again. That's the only thing. Otherwise, I think it's a well done station because you covered a lot of things, but only just to show the knowledge. You have to show to your examiner that what all you know. And you told rightly about the follow up. So there is no problem. Okay.
Okay.
Thank you, Priyanka. Thank you. It's a well done station. And I'm sure this would add value to for the people to prepare. Thank you.
Thank you. Thank you, Dr. Sonia.
Thank you.